Thank you. So I'm well aware that I stand between you and lunch, so I will try and be timely. First of all, let me say it's an honour to be here, really. I stand before you as an optometrist, and already just sitting in this morning, I wasn't here yesterday, but just sitting in here this morning, there's so much that my profession can take back from what I've heard already just this morning. And it goes to what John was just saying about making sure we're open about sharing our innovative plans and what we've been doing. So I'm going to take you on a little bit of a journey this morning. My purpose really is to help you understand what we've been doing in optometry. We're starting from a really low base in optometry. We haven't grasped the fundamentals of medical education. It really is in its infancy for us. We've been trying to do things differently in Wales for a few years now. I've been involved in postgraduate optometry education for the last 10 years. So I just wanted to share with you really the journey that we've been on and where we want to get to and how we recognise what we can add to the workforce, the medicine and medic workforce. So like most things, we start with a bit of a potted history of the profession. I think most of you won't have heard much of this before, but it wasn't until 1958 that you actually had an optometry regulator, the General Optical Council. Some of you, although I'm looking around the room and I can't see anybody that would know, but in 1978, eye tests were free to all that would remember. At the same time that the first test tube baby was being born, and that's the reason that's up there, anybody could have a free eye test. That was changed 10 years later when it was quickly abolished because it was costing a bit too much money, unless you live in Scotland. Now they still have free eye tests in Scotland, and there's some interesting things to learn from that. In 1989, the first regulation laws were passed in the Opticians Act, 1989, and it outlined what we needed to do within a sight test for the general public. It wasn't until 1994 that we first introduced CPD, and then again it was a further 11 years before it became compulsory, but it has been compulsory since then, so we have made some strides. In 1999, optometrists could actually refer direct to hospital. Believe it or not, before that, they always had to write to the GP and say, I think there's a problem with this patient, can you send them on to hospital? So thankfully that's been removed, where we can send it directly now into our ophthalmology colleagues. Believe it or not, Vladimir Putin first came as Russian president in 1999. I find that hard to believe, it's been in power so long. And then in 2006, along with other professions, independent prescribing was first allowed for optometry. So fast forward to 2010 in Wales, actually there's been enhanced services. So we were the earliest adopter in the UK to allow optometrists to see patients who self-refer with eye problems. So let's say they'd been in the garden, mowing the lawn, they'd got something in their eye, they come and see us, rather than having to go to the GP or A&E. So in 2010, we looked at the service that we'd been offering, and we realized that actually in order to gain some credibility with our other medical colleagues, we needed to ensure that all our optometrists were put through some nasty OSCEs and some training. So we offered it to the whole of the profession in Wales. You can imagine that was quite something at the time to say, well, you've already qualified. Actually, we're going to retest some of the competencies that you should have done. But we recognise that a lot of you had qualified before those competencies even came into existence. So we just want to make sure that you're all at the same level. And they did. They came forward. No protected time. They came in their own time. They did their education online in their own time. And they came forward to do OSCEs in their own time. So we wanted to have a look at how that went, and as you might expect, there were no failures on the MCQs related to the distance learning, but we found that 20% of optometrists failed at least one station, and out of those, the common stations were the skills ones. And that seems quite shocking that they could be practicing and yet still failing some of these skills. But actually, one of the skills that we tested was looking at the back of the eye with, it's not new, but something that was a more modern technique with an indirect ophthalmoscopy rather than the direct. Understandably, a lot of them, when we spoke to them afterwards and did some focus workshops, focus groups, they said nerves and the unfamiliar form of assessment really affected their performance. And we also saw that those optometrists that had been in practice for a long period of time were the ones that were more likely to fail the skills sessions, the skills assessments. So we looked at it a little bit further and we asked them all to fill out questionnaires to try and assess the effectiveness of the accreditation on the way that they work. We did use Kirkpatrick to try and look at that, and certainly the easier levels, we were unable to go much deeper at the level 4s, but we wanted to use that framework as a pragmatic way of evaluating what we'd done. So we got a really high percentage return, and we found that the vast majority, on a scale of 6 over 4, the numbers for respondents that felt the distance learning modules were good was very high. I'm very skeptical about that because I think, everybody likes that. It's not very challenging, is it? You can answer questions and then you get your points. So I wasn't overly surprised, but I was also a little bit, well, that doesn't prove much. They did feel the modules were related to practice, so we at least got that right. How did they feel about the OSCEs? And that was the more interesting one. At the top of the scale, most of them, the majority, realized that it was necessary to prove their worth and that it was a good test of their ability. But down the bottom, a surprising percentage found the experience traumatic. I guess if you're a professional, and then I asked you, well, actually, I know you've been qualified for 15, 20 years, but I need you to do this assessment that you might not have done before, you'd probably find it traumatic too. So maybe that wasn't overly surprising. As I said previously, we found there was about a 20% failure rate, so that gave us our level 2 of Kirkpatrick. And when we analysed it, looking at those that had failed at their first attempt, on the graph here, the columns really indicate the numbers, and then the darker maroon is the percentage. And you can see that there seems to be this trend that the longer that you'd been qualified, the more likely you were to fail an OSCE, which again, kind of fits with what you'd expect. We also asked them if they felt they'd learned something and then taken it forward to their practice, and the majority did feel that, so we looked on this as positive. But sadly, had it affected the way they practice? Not many of them said yes. In fact, the majority said no. So fine, we took those away. We looked at specific skills and what they felt they had learned and what they felt had made them better. We looked at that for development purposes. The conclusions are thus. They felt that distance learning was good, enjoyable, relevant, although as I said, I never feel that's very, very challenging. OSCE is necessary, although traumatic. Longer the time since qualification, the less likely they were to pass first time. And the majority felt that they have used little bits from the accreditation. So that was great. But we fast forward then another couple of years, and we recognised the isolation of practitioners working. And so we introduced case-based discussion, and we were again the first ones to do that on a mandatory basis in Wales. So we said to them, look, if you want to continue offering these services, then you have to come in, you have to sit around a table, and we're going to discuss these cases with you, and you're going to talk to your peers. And believe it or not, other areas of the UK weren't doing that at the time. And the subtext, we were actually ahead of the game in terms of our regulator mandating that too. So although we were behind the curve for many other professions, at least in Wales, we were already ahead of the regulator. So I can blow my own trumpet a little bit there. So we asked them to participate. We wanted to evaluate this. We asked them to participate 3 groups over 18 months. Typical kind of case-based discussion or peer discussion. We held 11 events over 8 locations in a study period where we looked at an evaluation. And one of the main drivers for this was we wanted to improve our letters and referrals to secondary care. So in terms of how we evaluated it, again, we used Kirkpatrick's framework, and we did it in the 2-month period between January and February 2012. We did a pre-immediate post and then a 3-month post-Questionnaire. And we used statement-based comments for them to rate. We actually got really good participation in terms of the pre- and post-immediate post-Questionnaire, and quite a good one for the 3-month post as well. We kind of sat on them a little bit and followed them up very carefully. We were surprised at how positively it was received, with 94% felt that they were keen to learn in this way, and only 6% felt that they didn't need to do this, although there were some that were ambivalent. In terms of the immediate post-Questionnaire, we wanted to find out whether people felt reticent to share their views in the group. And actually, when we cross-matched this, we found that often women and part-time workers were more reticent. A lot of them said it was a good way to learn. And the knowledge, so we tested immediately pre-Questionnaire and post-Questionnaire some knowledge questions. And those that had spent more time since qualification and those that were working in isolation found that they had better increased their knowledge compared to what they previously thought. And that was in all areas, really. So then we wanted to see if they felt that it had changed their self-reported practice. And indeed, we did find a majority of them, particularly in the areas of things like improved referral writing, which was one of our goals, as well as the use of antibiotic ointments and drops for the eyes. It also, surprisingly, did feel helped them identify their further needs. So we actually relayed this to the regulator. They were already thinking about mandating it, and they pushed forward with their plans. This, though, to me, was probably, we're talking about being pragmatic about these things, and this was probably the thing that drove home the most what it meant to the people coming together, was that before that, believe it or not, some optometrists, you probably know, going to community optometrists, they work in isolation. They're not like secondary care workers. So bringing them together really had an impact on them. And since this, we've made sure we bring them together every year. It also says to me that there are several things that come out of this. One, if you're practicing in isolation, then really your knowledge base and your soundboard of what you know, you've got nobody to bounce off. And that's likely to go down and down, and your skills and your knowledge aren't being tested. That's one of the major issues that we have in optometry. The other issue I think we really have in optometry is that if we want to move forward with what we're doing and do more, and even take patients out of hospitals to see them in communities, to examine them and manage them, then we've got to understand that an optometrist, when they're clinical decision making, so they're seeing a patient, they recognise possibly what it is, they write the letter, and then that's it. They're not getting feedback. They don't know how can they clinically decision make without knowing what happened to that patient in the long term. I know a lot of optometrists like me, we actually end up phoning patients, say, what happened when you went to hospital? Because believe it or not, our response rate, I'm not having a go at secondary care, seeing a colleague on the front row, but in several studies, response rates is usually 10% or less from you sending the patient in to getting a letter or any sort of communication back. So in that way, in many instances, I think we need to work much more closely with our colleagues. We need to spend more time in secondary care, and I'll come on to that in a bit. And we need to stop them being isolated. So here we are up to date now. What we've done this year is we've actually recognised that a lot of patients end up in... before I go into that, just a bit of a break about optometry and then looking at CPD across providers. We did a scoping exercise recently where we looked at all the providers' CPD requirements. And I thought this was interesting to share with you because you'll all be coming from different disciplines, and nursing, midwifery, dentistry, optometry, medicine. They'll all have their regulators, but there is a big kind of spectrum of what different regulators mandate. So 8 out of 9 of the ones we looked at don't mandate modes of what CPD you do. I'm here today, and I think that's at least we're moving forward there, but there's no mandated interprofessional CPD. 82% of those registers are required to inform of some form of reflection in learning, but only 35 are required to use PDP plans. That's out of all the regulators. And 26% have no requirement to engage in peer-to-peer learning or case-based discussions. So I think we need to get to grips with that. But that was just my aside before I move forward with what we're doing now in optometry. One of the things that turns up a lot in secondary care, particularly in ED, A&E, whatever you want to call it, departments, is people with stuff in their eyes. Optometrists in Wales have been removing, I remember doing my pre-reg 25, 30 years ago in a practice where the person in that practice took a needle to someone's eye and took out all the rust ring that had been there after they'd had a removal in hospital of an initial rust particle. So optometrists have been practicing this for some time, but certainly it wasn't widespread. We recognise that we want to try and stop patients getting into secondary care in the first place and do what we can do in community primary care. So we've done a series of practical skills workshops to upskill them to see the patients to be comfortable with removing things with needles. We looked at an initial questionnaire, and we'll be following it up. And again, using a bit of Kirkpatrick's, this time the benefits we hope to see on practice change is we'll be looking at the forms that the optometrists have to fill in to get their payments and saying how many times was it done before and after this skills-based practicals. And we will also be looking at secondary care in what comes in terms of foreign body removals to see if we've made a difference to actual practice. Our initial questionnaires actually showed us that less than half say that they do it at the moment. So if we can get them all trained up, they can all be ready for when those patients come in. And certainly when you work in practice, this does happen on a fairly regular basis. In some areas, it happens on a very regular basis. If we can prevent those patients getting into ED, A&E, that's great. Our other considerations really for eye care in Wales now and things that I'm trying to work on in the systems with HEIW is we know all the problems with secondary care basis for ophthalmology. And I think it kind of cuts across most disciplines. We want to make sure hospitals only for those that need it. If we can take out a fairly superficial foreign body out of the eye and deal with the consequences of that, then we're doing a job in keeping patients out of secondary care. We also know that there are some patients, where appropriate to do so, that we could see who are being seen in hospitals, but we could bring them in and see them in communities. And certainly we need to work a lot closer together. So this is just to show you what's easy and what we have done in Wales. We know that in Wales we've got 380 odd practices in optometry, and they're situated in all areas of Wales, including areas of social deprivation. And the graphs there just show you that there is indeed coverage. We already do the acute care management. We're going to be doing the foreign body stuff. We also see patients who've had cataract operations that have gone well and they haven't had any pre-existing conditions. So there's the straightforward stuff. We're seeing a large percentage of them for their follow-ups in community. And we know that there are frameworks out there that are NICE endorsed that allow us to do more in communities as well. What's not so easy is the cultural barriers and the trust between professions. As I said, if you're an ophthalmologist sitting in secondary care, dealing with the referrals that come through from an optometrist, you're probably going to get some rubbish referrals. You're going to get some good ones, but understandably, once you get a few rubbish ones, your bias kicks in and you're probably always looking for the rubbish ones. We also know that there isn't a lot of decent electronic communication. It still relies on letters at the moment. There is a big process in place in Wales to have e-referrals within a year, we hope. And then we will be able to get direct communication. But we also know from studies that newly qualified optometrists are risk averse. We don't have any foundation year. Once you're qualified, you can go from being with a supervisor every day and working in a team to being an isolated practitioner on your own. And understandably, again, some of those people are very risk averse and end up sending a lot of referrals in. So the work we need to do is we need to make sure that optometrists are continually trained up. We need to provide more placements, as I said earlier. We really want to work with secondary care so that the experiences that you get of managing patients and seeing it through to see what the impact of your management on that patient is, you get better experience of that than you do currently in community care. And we also want to help and support newly qualified optometrists to make better decision making on their referrals by providing some support in their first year. So whilst it's not a foundation year, at least we're moving towards that when in HEIW. Okay, am I above time? I thought it was going to be miles behind time, so great. So you might have an early lunch. Thank you very much.